So my apologies. I did originally want to get up to Grand Prairie for this session, but just due to sort of balancing some personal things, it wasn't able to happen. So I'm Vijay Daniels. I have been the Assistant Dean of Assessment in the MD program for almost 8 years, but I'm actually stepping down a little early to take on a new exciting role, Director of Teacher Support in clerkship. So I'll be working with Mark as well as Karen and Joanne down in Edmonton. Um, I just want to make sure everybody can still hear me okay. Elfrida, can you give me a thumbs up? For some reason, the camera's on you. Thank you. I do want to do a land acknowledgement. This is very important. So the University of Alberta, myself, its buildings, labs, research stations are located primarily on the territory of the Nahia, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as part of Treaty 6, 7, and 8, and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit. I don't have any, these are my disclosures, I don't have any relationship, so that would cause a conflict. So some definitions. Again, a lot of you may know this. I just sort of work on the assumption we know very little, just to set the expectations. But assessment of learners is to sort of judge their performance for two purposes. It can be used formatively to inform their progress, and it can be used summatively to sum up how they have done at the end of a time period. And so actually in health professions education, it's very interesting because we actually kind of use a lot of our assessments for both almost all of the time. The only thing that is probably truly summative is your very final certification exam from the CFPC or the Royal College. Even our sort of more higher stakes things, if students struggle, we go over with them to try and build them up to help them get better. Evaluation is sometimes used synonymously with assessment, but the majority of health professions educators would use evaluation more to refer to a program evaluation, evaluating teachers and programs. Now, one of the sources of data for program evaluation is assessments. We often say if 2% of students struggle on an exam, that's probably a student issue. If 50% of students struggle on the exam, that's program evaluation of a curricular issue. So our objectives today is first to describe what assessment methods we use in the MD program and why. I'm getting a little bit of noise from some mic over there, just letting you know. So assessment methods we use. The most common one we're probably all familiar with is select response questions, where learners select from a list that can be the classic MCQ, but things like true, false, and matching also play into that. Construct response questions are where learners write in their answers. That can be short answer questions or long answers. And there are pros and cons to both of these methods. Oral exams is something that we use in psychiatry and sometimes on some of our OSCEs as well as our anatomy makeup exams. This is where there's an interaction between an examiner and the candidate. Now they can be very structured with very specific probing questions, or they can be a little bit more unstructured. And examiners can also provide patient information, sort of physical exam findings, lab images, that sort of things. OSCEs, a lot of you will be familiar with, and sometimes there's a conflation of OSCEs and standardized patients, but the definition of an OSCE is just that you rotate between rooms with different examiners, and there's different content in the rooms. Now, classically, OSCEs are standardized patient-based of history and physical, but you can have a whole OSCE where every station is an oral exam. The OSCE method is actually about the rotating so that you experience different cases by different examiners. And the reason for that is it removes the halo effect of you doing poorly on the first case and then having to sit with the examiner for the next 2 hours. And that biases them throughout. Workplace-based assessment, something we've come into a bit better focus. Certainly our family medicine colleagues have been doing this longer than we have in Royal College specialties, but it's any assessment in the clinical environment, and they can be more longitudinal, like end of a week or end of a month, or they can be what I'd call task-specific. Many of you have done medical school at a time where we had the mini CEX, and now we have field notes and EPA observations. And I'm going to categorize EPAs and field notes together because their sort of driving purpose is the same. And so competency-based medical education really is an overarching approach to assessment that links those individual assessment encounters to master objectives. At least in The Royal College model, they focus a lot on EPA observations, probably excessively so. And in family medicine using field notes, and I believe there's sort of a move to core professional activity observations as well, is again, as I said, a similar building block. So that was just a quick blitz over what the assessment methods are. But what I really want to focus most of our time on is discussing the why. Why do we choose something? What are the strengths and what are the drawbacks? So when I started my master's in health professional education, this was one of the first things that I learned in assessment was Miller's pyramid. And George Miller actually defined this in 1990. So this is not a new concept. Some of you in the room may have seen this, but it has 4 levels to the pyramid. And at the lowest level, the way Miller argued it is nose is knowing sort of the often fact recall underlying constructs such as, can you explain the role of the RAS system and CHF? That is important. We shouldn't get away from basic sciences because it does serve an important purpose. But if we leave our exams there, we're missing quite a lot. The knows how is someone who's able to take that and apply it, especially in our world, to the clinical venue, and knows how it would be describing the diagnosis and management of congestive heart failure. Shows how, the way I think of it, is in vitro performance. It's standardized in a simulated setting, take a history from and examine an actor that has signs of congestive heart failure. And the does is the actual real life in vivo, take a history from and examine the real patient to diagnose and manage CHF. I think we'd all agree what we want out of our trainings at the end of the day is the does. And I'm not disagreeing with that, but I'm going to talk about the different assessments and why we still use them instead of just focusing on workplace-based assessment. So, knows, fact recall. Knows how is more interpretation and application. Shows is actually demonstrating in a structured standardized setting. Does is performance in real practice. So MCQs and short answer questions, we still use them, and there is a reason for that. They are actually the most efficient way at broadly sampling the knows and knows how level. You can have a student sit down and do a 100-item MCQ much faster than it would be to actually sample all those domains in real life or in an OSCE. So they do still serve a role. Oral exams and OSCEs are interesting, and where OSCEs especially came from in the 90s was really focusing on that shows. Can we have learners demonstrate in a standardized setting? That way every learner does experience the same thing. In oral exams, although sometimes it gets at a bit of nose in terms of fact recall, and oftentimes we inappropriately focus an oral exam on this lower level knowledge. Not to say it's not important, but the whole idea is you really want to show, or the learners need to show their clinical reasoning and decision making, and that's the strength of an oral exam. And of course, workplace-based assessment and frameworks like competency-based medical education, the CCC curriculum, really does focus on the does, performance in real practice. So the argument I make, as framed by Miller's pyramid, is all of these are important, but they're complementary. I'm going to talk a bit more about that. So, for many of you who've had third-year students working with you, whether it's a family medicine setting or other setting, you may have had to fill in our MD program assessment form. So this form was revised back in 2017-2018, and it's okay if you can't read the text on the slide, but the idea it was to describe in a longitudinal exposure the behaviors we want to see in our learners. So for example, interpersonal skills, I'll read this one off. When students are starting a given clerkship, they can be sometimes awkward, using inappropriate terms, minimal use of open-ended questions, and mostly attentive. But what we really are pushing them to get by the end is mostly at ease, clear questions, appropriate use of open and closed-ended questions, and attend to the patient's answers. What this allows is both summatively saying, are they there? But formatively, I meet with a student 2 weeks into an 8-week internal medicine clerkship. If they're struggling here, it is my job as the teacher to help them get to the next stage. And hence why I was saying a lot of the assessments we do in the MD program is a combination of summative and formative. Now, in trustable professional activities, again, I'm using this phrase, but it's similar to field notes. And it is still something to this day, despite Royal College programs having launched easily, 5 to 8 years of this, there's still a lot of confusion. And one of the key things is it is an activity or behavior, kind of like the sentinel habits of family medicine, that can be entrusted to a learner. And a bread and butter one in our medical school would be obtain a history and perform a physical adapted to a patient's clinical situation. I think we could all agree by the end of medical school, students should be able to do a basic approach to this. Another one would be propose an initial management plan for commonly encountered presentations and diagnoses, or a harder one that doesn't happen as often for a medical student, but we still think it's important, is communicate in difficult or challenging situations with patients, family, advocates, colleagues, or other healthcare team members. So hopefully we'd all agree students should get exposure to this, students should be assessed on this, students should get feedback on this to help them develop these skills before they start residency. Now, these are just examples of at a medical school level. You can think of your own specialty programs where you would up it to the next level. Key thing is we need multiple observations across time and different contexts. A student can't just collect their history taking EPAs on internal medicine and say that's good enough, because it is very context specific. How they do on obs-gyne, family medicine, surgical cases, all that sort of things is important to truly build the picture. They can take a history across different contexts. And here's the big thing. The University of Alberta were pioneers in launching OSCEs in the late 90s, early 2000s. However, it felt like it was almost focused so much on OSCEs, we weren't doing enough in real life. And that was the whole point of this shift back to workplace-based assessment. So what our entrustable professional activities forms look like, I'm giving you two examples. The top one is what we see in our medical school. The idea is the top level is someone you're expecting to be at or above the minimum expectation for first day residency. Some people dislike how vague that term is, but we tried many different permutations, and this felt like the one where most assessors could picture that resident in their discipline on the first day of residency doing call and could judge is how far is the student away from that. And again, one of the things I want to emphasize is competence is not excellence. Competence, this will sound bad, but it is a lower bar than we often think. And I'm going to give you a specific example. Last week was observing, in my opinion, a strong medical student do a neurologic exam. She was able to figure out that the patient had both Parkinsonian findings and spastic findings with her tone exam and her motor exam. Her reflex technique was good. She was slightly off on the cerebellar testing where she didn't stand far enough back during finger to nose. Some people would say you have to be perfect to be at the level first day of residency. I was like, no, can this student detect a stroke on the first day of residency, detect Parkinsonism on the first day of residency? Yes. Does her cerebellar testing need to be improved? Yes. And so one of the things that I always encourage people is thinking, we're not talking about being perfect, we're talking about being safe. So the first one, as I said, is for the MD program. The bottom one is what Royal College disciplines have largely rolled out. And this is more describing what the teacher had to do. I have mixed feelings about the O score. That's what it's called on the bottom. It works quite well in procedural skills, a surgeon screening into an OR. It's maybe not the greatest language for non-procedural things, like you're reviewing a case like 2 hours after the resident saw the patient and already did some initial management. So although I believe there's a role for competency-based medical education, I'm not someone who's drunk the Kool-Aid and says this thing is perfect. And a lot of my research has been interrogating what we can do better. So as I was saying, these are what are minimally competent for graduation, but we're not saying that these are experts. And one of the other things that I'd encourage you is just because you click the top box for whatever it is with field notes, the carry-on got it, the MD programs, EPA forms, that does not mean top box equals no feedback, because there's always ways to push learners beyond competent to proficient and excellence. One tip I'll also give you, and I don't want to steal Lillian Au's thunder, but a question I often ask learners when they seem to be really good at the case is, what if? So what if instead of the creatinine being 100, it was 400? How would that change your management of heart failure? That doesn't mean they weren't independent for this simple case, but it helps you teach them. So as you can see, our more longitudinal form is exactly that. Over this rotation, where are they at? Whereas an entrustable professional activity or task-based form is really looking at how did you do on this case. And I hope you'll appreciate that these two are complementary. Using the CanMEDS framework, this is not perfectly mapped on, but in my experience, medical expert and communicator, we get more data on that direct observation. I'll be honest, prior to the launch of CBME, I probably didn't observe my learners in the room talking to families as much as I should have. Whereas things like professionalism, how they manage the team if they're a senior resident, how they advocate for the patient, I see that on a week of service. And so I would say both of these are complementary. There is no such thing as a professionalism EPA, right? Professionalism is continuously doing what you should be doing for your patient, showing up on time, working with the team. And so that's what I want to really impart here, that we need both. Another way to say it is EPAs are that discrete observation of a task, and other workplace-based assessments are the overall impression of the preceptor over time, and combining the two is the best reflection. I am trying to move fast to help your agenda today, so I'm going to keep going, but we will have time for questions at the end. So now I'm going to move into things that are a little bit higher level that I sort of learned in my master's. And we're going to talk about something called validity, because that's actually the most important thing when we talk about assessment, is validity. And you may have heard of different terms of validity in the past. We have sort of a more modern view where it really is a unitary concept. And essentially the question we're asking is, what's the evidence you present to support that you can support or refute, the meaning or interpretation assigned to these assessment results? I think if I said to you, you're going to have a one-station OSCE, and this determines you passing medical school, you'd all say that doesn't make any sense. You know there's a problem there. Well, what validity does is give you some language to establish where the problem is with that. Kane is one of the modern examples of this, and the way it works is you first have to state, what are you going to do with the assessment? Because that's really key. A lot of people want to introduce an assessment, but the question is, for what purpose? And then decide, do you actually have robust evidence to do it? So the evidence we need for a lower stakes end of first year physical exam OSCE, where our main goal is to give feedback, is much lower than at a national certification exam. That's the way to think of it. So I'm going to walk you through this and use an example of an OSCE to just sort of paint a picture. So for those who haven't been an OSCE examiner, you are in the room observing a student, say, examine a knee, take a history for chest pain, and then you're scoring it on a sheet. So the first, there's sort of 5 things that happen, and then there's 4 what I call steps or inferences. So you observe the encounter, and that leads to the scoring step where it translates onto a single score. And in an MCQ, that is less of a threat because there's not a lot of other things that are impacting that. Whereas in an OSCE, if your pager goes off or there's construction next door, and these are things that can happen, that's going to impact your ability to score it. Or if you look at the score sheet and you're like, I don't even understand what it's asking me, that also is going to impact your ability to reflect what you observed as a true score. That's the stage of scoring. Generalization is how well blueprinted is your exam. So if you have an MCQ exam that's supposed to cover all of medicine for a graduating medical student, and half of the questions are obs-gynae, we would all agree that doesn't seem appropriately blueprinted. And generalization, the way we talk about it in sort of assessment language is, does this set of items represent the infinite universe of possible items? And this is where, if you've done a little bit of the work, you've heard of things like alpha reliability. That's how we look at these things. But it's not just about stats, it's about how did you blueprint it. And good assessments should tell the students what the blueprint is, and we do tell our students that for our higher stakes exams in the MD program. In our pre-clerkship courses, sometimes the blueprint is just, it's going to be X number of questions per week of block content, and it's mapped across all the blueprints, all the classes. So that's generalization. How well does the test represent all possible items? Extrapolation, this is why I love Kane's example compared to others. Extrapolation is, so how well does the test extrapolate to real life? So if I said we only did MCQs in the MD program. We didn't care about workplace-based assessment. We didn't care about clinical skills. I think all of you would say that's completely inappropriate. And that's because MCQs does not have a lot of evidence for extrapolation to real life. Whereas OSCEs would be closer and workplace-based assessment even better. But if I use the example of workplace-based assessment, what you will see with your student in a 6-week family or 8-week family medicine clerkship is not going to be the same as you see with the next student. So you can see how generalization may be less robust evidence compared to the extrapolation to real life. When I teach people how to write OSCE stations, the first question is, would you actually only give them 6 minutes to do this task in real life? If so, why are you asking them to do this in an OSCE? And sometimes the answer is time constraints, but then you need to trim down the task so it's not so overwhelming where they have to speak really fast, ask close-ended questions because they only have 6 minutes to counsel someone on their goals of care. So that's the extrapolation stage. The last implication is a bit harder to wrap your head around, but it has to do with how we set the pass mark and what are the implications of failing this test. Does getting remediation and taking the test again allow them to improve? Or is the test testing something completely irrelevant? So I have like hour-long lectures on validity. That was like my 4-minute snapper to sort of understand the concept. And I'm going to give some examples. So just to recap, does the observation lead to accurate scores? Were the observations sampled appropriately? How good does your quote unquote test represent real life? And this also, even though I was sort of being a bit dismissive of MCQs, an MCQ that's just asking you to recall the Krebs cycle versus asking you a question that actually has a patient presenting, the latter is going to have more evidence of extrapolation to real life. And implications is getting at what are the implications of failing? How did we determine what the pass mark was? The two big buckets when we think broadly of what are threats to validity are construct underrepresentation, which is just you didn't sample appropriately or your sampling was biased. And then everything else is a fancy term, construct irrelevant variance. An example is we sometimes are testing reading time on an MCQ instead of actual testing the construct because the exam is a race. You don't want that. We've even talked about this at high stakes exams nationally. When should time be a factor? And really, it's if you're running a code, then time needs to be a factor. But in an artificial oral exam, allowing a learner more time to express their thoughts is not a problem. So time is rarely to be something that we use intentionally as part of our exam. So I'm going to give you some examples of the balance between some of these steps. So if I have 10 observations with every student getting the same experience in an OSCE, that's good from a reliability generalization point of view. However, 10 observations in the workplace with every student getting a different experience is going to be less reliable, less generalizable, but it's going to be way more authentic and better for extrapolation in Kane's model. If you have 12 stations that are focused just on physical exam, that's going to give you a very reliable measure of physical exam, but you can already see, well, it's not generalizing to other skills, as opposed to 3 history taking, 3 physical exam, 3 procedural stations, 3 oral stations is going to be a better sort of representation of real life. So we make these decisions across our MD program into PGME. Medical students in our third-year clerkship who need to be assessed in 6 large areas in 1 year to pass third year, we do heavily use OSCEs as part of that because we need to have standardizations. As opposed to when you're in a 5-year training program or even 2 years for family medicine, where you have lots of richness of the clinical environment, you have far more time that, you get actually a lot of sampling in an authentic environment. So again, it's not that OSCEs are perfect. They have a role. They're picked for a certain reason where you have more time, spend more time on workplace-based assessment because that's actually real life. All right, we're getting to our sort of last objective, talking about a concept of utility of assessment. So validity was asking the question, can I trust these marks to make the inference I want to? Those who know me know my wife is a prof in the Faculty of Education, and A Friday night discussion in our house was about what the heck do we do with AI and how is it impacting assessment? Because my wife actually holds a role with CTL as a CTL scholar and trying to think these big questions. And it is a question of validity. What can we do? I would love to say every exam on campus needs to be in-person proctored. Here's the problem: utility. Can we actually do it? Do we have the physical space? What are the costs associated with it? So validity, while it's good, has to be couched in the big picture of what are the other aspects. So the way it was originally described back in 96 by Kees van der Vleuten is there were kind of 5 pillars. I put reliability and validity together because they're so intrinsically related. Reliability now is viewed as a subset of validity, as I explained. But what's the educational impact on this assessment? We know one of the best uses of assessments is to drive learning. And there is an important role to that. But cost is absolutely a factor that we need to be thinking about. What is the cost to this? And we have these discussions all the time in the MD program, is can we do it 95% as well at 80% of the cost? These are discussions you have and to think about it. And acceptability. There is something that's really important about the launch of workplace-based assessments, competency-based frameworks, where acceptability was possibly ignored too much at implementation, and we need to think more about that. So honestly, whenever I get asked to help with assessments, this is basically my motif. My mantra is it's always a constant tug of war, what you're balancing. As Dr. Hemelgarn knows, I'm actually helping another faculty outside within our college, but in one of their national licensing exam, and I use the same example. It's like, how many OSCE stations do you need for your national exam? It's going to depend on cost and what you're trying to do here. So this is one side of the tug of war. We need to run a massive OSCE with tons of paid actors to get a true sense of what they can do. That's going to cost a lot of money. Are you sure we really need to do it this way? And this always needs to be something we think about. We should let the learners see their OSCE score sheets for their learning. Like, that is actually something we do in the MD program for their year 1 and 2 physical exam OSCE stations. And the reason is, when you show a student they missed examining the JVP or whatever it is, it's not really giving away the exam bank. However, when you have other more sensitive or complex OSCE stations where what they're testing is something very specific, showing the students the actual checklist may give it away and compromise your exam if shadow exam banks develop as a result of this. So again, it is always a balance in this way. We need reliable and authentic workplace-based assessments. So let's mandate a week that all the students get 2 observations from their preceptor every single day. I'm hoping lots of you in the crowd are like this. No, the teachers will protest. And again, this is where the balance is. Where do we strike the right balance as how many workplace-based observations? This is not a validity question. This is a utility question. And that's why validity is important, but it needs to be couched in the larger picture. So I blitzed through that because I did want to help you get back on track, but I also want to have time for questions because there's a lot of concepts that I've covered. But choosing the right assessment depends on what are you trying to assess. There is still a role for knows and knows how. Basic science is very important to understanding the pathophysiology, but there is often a better way to get at that basic science without just asking it as a nose level question, incorporating more of the clinical aspect to these questions. There is a constant tension between all aspects of utility, right? Having a more valid exam, you're going to put more effort into it, but then what is it at a cost of? You want exam integrity, you're not going to give any feedback to your learners. Well, that won't go over well. And if it's lower stakes exam assessment, we should be giving more feedback to our learners. What's the cost related to this? And what's the acceptability both to the teachers and to the students? So at national certification exams, 2 days of exams for a candidate is going to give you more data than 1 day. but is that going to be acceptable? And what is the cost associated with that? So there is no one assessment method that is the gold standard. It is really considering the context. What are you trying to do with this assessment? That has to be the first question whenever someone says, I think we need to introduce a new assessment. What are you trying to do? What is missing? And then thinking about all of this. You do need to use complementary methods to balance those demands, but the balance between MCQs, OSCE orals, and workplace is going to shift very heavily. In pre-clerkship, we're on one end, and clerkship, we're sort of moving towards more the OSCEs, more workplace-based, and residency, it's going to be heavily workplace-based assessment. So with that, I'm happy to take questions.